Okay, this is a 10 years old boy, Hatim. Please do MSK examination for him. MSK of lower limbs.
Okay. So first of all, I will introduce myself and take permission from the mother and do hand hygiene and go to Hatim and make rapport with him and check whether he is communicating with me.
Yeah, he is well communicating.
Okay, then I would like to plot his weight and height in the growth chart because he looks short.
Okay. No need to plot.
Okay.
Then
I would like
weight and height under 0.4 centile.
Okay, under point. Okay. Then I would see any family members who has similar features.
Yes, his brother has similar features. This top picture is for the brother. The C1 picture is for the brother. These two pictures for Hatim, A and C is for Hatim, B is for brother. Yes, the brother has like this on the head. Okay.
Okay. Then I would like to also see for any dysmorphic features. I can see some. This child has some depressed bridge or maybe normal also.
Okay.
And some dental abnormalities with this child.
Okay, dental.
That I will describe while presenting.
Okay.
Then I will, for MSK, I would ask the 3 questions.
Okay.
Regarding whether he has any pain anywhere in the muscles, in the bones, in the back, and
yes,
any difficulty in buttoning. Yeah.
Yes, he has pain. Yes. Pain in the legs when he walks, he has.
Okay. Then any difficulty in buttoning, unbuttoning, and any difficulty in going upstairs and downstairs.
Yes, he has some difficulty in going upstairs and downstairs because of this deformity in the legs, and buttoning, unbuttoning he can do.
Okay. Then I will tell him to walk. So, and before walking, I will just observe his legs, where to look for any like any changes in the bulk, any leg length discrepancy, deformity. I can see already in the
describe
leg.
the deformity.
It's like knock knee deformity, which I can see, and it is more on the left than on the right.
Okay.
And yeah.
Knee deformity. And then what else you want to check in inspection?
In inspection, any scar mark, any asymmetry, and yeah, any skin rashes, any changes other than this, and also any malleolar prominence, medial malleolar prominence. And also I would like to, also I can see like other features of rickets, like wrist widening, ricketic rosary also I can see.
Okay. So
and
after the inspection, what is the next step? Go ahead.
Yeah, next then I will tell him to walk for me. So he
he walks in the same way, in the same position like this. He walks in the same way, keeping the legs like this only with difficulty.
Okay. Then I think it will be difficult for him to walk on the tiptoe and heel walk, right?
Yeah.
Or can he walk?
It's difficult for him.
Okay. Then firstly, I will do the upper limb P-gulls also to look for any deformity. So I will tell him to make it straight hands, and then also make a fist.
Lower limb. Wait, please, P-gulls of lower limb. Please take care of my, please.
Hello, it's P-gulls general, right? You told. No, MSK general or lower limb?
I told lower limb.
Okay. Then I will proceed. I will check the back then. To look for any like any hyperextensibility, like he can touch the floor with the hand. Is there anything I can see?
Yeah, he can touch the floor with hand.
Okay. Any kyphoscoliosis on the back?
Mild scoliosis.
Mild scoliosis. Okay, then I will tell him to lie down on the bed and do all the movements at the hip, knee, and the ankle. Okay. So is he doing passively? I will tell him to do, and whether he's doing it.
You will tell active first. Okay. Active, you want him to move actively. You want him to flex his knee, you will show him, or what?
the movement.
Okay, he is able to flex his knee and also extend the knee. And what else you want to do?
Flex the knee and extend the knee. Okay. Any restriction at the knee?
Sorry, he for the hip, yes, he can flex and extend. Anything else you want to do in PGALs?
Yeah, in that, then I will do the internal and external rotation by keeping at 90 degree and see if there is any rotation is okay. And in the
Hip is
knee,
okay. Hip is okay. Next, what you
yeah,
want?
knee, I will check for the flexion, extension. Then I will look for the cross fluctuation and also patellar tap.
Okay, he has problem in the flexion. He cannot flex completely, and also extension he cannot do completely. There is restriction of movements in knee. Next.
Okay. Next, I will check the ankles to do the plantar flexion, and then also the extension, the inversion, eversion movement. I will check.
Yeah, in eversion has a problem.
Hmm.
Inversion is okay. Eversion he has a problem. Otherwise, other movements are fine. Next.
Next, I would like to do the general examination to look for any like he has ricketic features, so to look for other signs of rickets and also if any underlying illness.
Okay. Go ahead.
So can I proceed?
Yes.
Okay, so I will start with the hand to look for to make the star and make a fist, and then I will check the wrist.
He can make a star
Okay.
and fist. Yes, wrist.
Okay,
Yeah,
anything
there is
abnormality
some
I can see?
broadening. There is some broadening in his wrist.
Okay, wrist widening is there. Okay,
Hmm.
also to complete this hyperextensibility, I will try to do the thumb to touch the forearm and extend the little finger.
Yeah, he can do that. His thumb will come to forearm and also the little finger. Okay, next, what do you want to do?
Next, I will also like to check the pulse and the blood pressure for this child.
Fine, they are fine. Next.
Okay, then I will see the face to look for this. I can see alopecia. Also, I will check for the pallor in the conjunctiva. And in the mouth, I will look for any highest palate and
Yeah.
also any abnormal teeth, which I can see.
No high arch palate, but teeth you can see, and conjunctiva, no pallor. Okay.
Okay, then chest, I will inspect for any ricketic rosary, any Harrisel sulcus, any excavatum carinatum. All this
yeah,
I will
it is
inspect.
there. You can see in the picture.
Yeah,
There
there is ricketic rosary.
and slight excavatum is there here. Okay. And
Okay.
what else you want to check?
Okay, I will just auscultate and then I will proceed to the auscultate. Yeah, if anything, and then proceed to the abdomen to look for any scar mark, any organomegaly.
Yeah, slight, you can palpate the liver slightly, otherwise no problem. Do you see the abdomen distended here?
Yes, abdomen looks distended.
Okay.
Yeah.
Next.
Then yeah, so
okay,
to complete my examination, I would like to check the blood pressure for this child and do the sorry, how old is the child? This one?
It's 10 years.
10 years. I would like to complete with the Tanner staging.
Okay.
Okay, and yeah.
What about the PGALs?
And also upper limb, upper limb P-GALS, complete the P-GALS examination.
Okay. So can you give the differential, can you present your case and give differential diagnosis?
Yeah, today I examined 10-year-old Hatim who looks short for age, and I can see there is alopecia, and also he has some abnormal teeth. He has, in general, he has this knock knee with malleolar prominence, and there is wrist widening, and also has abnormal teeth with ricketic rosary. Abdomen is distended with the liver is just palpable. And in the lower limb examination, the child, there is restriction of the movement in the knee, both flexion and extension. Yeah, these are the findings I got on examination.
Okay, you did not tell about the hyperextension in your presentation.
Yeah.
And also about the alopecia. Okay.
Alopecia, okay. Yeah, there is features of hyperextension in all the limbs. So, and Witten score is almost like
How much is
9.
the Witten score?
Witten score, I can see. Actually, I did not see the hands. So, at the elbow. So, I will keep it as maybe 7 to 8.
7, because in the knee you cannot elicit in the knee. Okay, differential diagnosis.
Differential diagnosis is it's a case of rickets. So it could be because of the lower limb or generalized involvement, and with alopecia, I will put first differential as vitamin D dependent rickets,
Okay.
and then other type of rickets like could be nutritional but unlikely to present so late, and other thing is could be any underlying causes causing this rickets,
Like underlying causes
like any um, kidney diseases or any liver problem, and also regarding any drugs like anti-epileptic drugs the child is on, or any other chronic illness like celiac or yeah, any malabsorption disorders.
Okay. So I want to know, in vitamin D dependent, which type is this?
This is type 2.
Okay, it is also known as
This is the receptor defect which they have, but
it is also known as vitamin D resistant rickets. Okay.
yeah.
So how do you want to manage investigations and management of this patient?
Yeah, investigation, I would like to do the complete blood count to look for any associated anemia, then bone profile, like calcium, phosphorus, alkaline phosphatase, parathormone, parathormone, and also I would like to do the vitamin D levels and X-rays of the bone.
Okay. What do you see in the vitamin D level in these patients? When you do
Vitamin D,
level,
yeah, vitamin D levels may be high because it is the defect in the receptor level where it is not working, so it should be high.
okay. So what treatment you will give?
For this, the treatment is higher dose of vitamin D
Okay.
need to be given for these children, along with the calcium supplement if there is associated hypocalcemia.
High dose vitamin D. Apart from that, any bisphosphonates can help in this child or no?
Bisphosphonates.
Okay, no problem. Time finish.
Yeah.
Okay. I will mute first. I don't know why they are opening the mic and mute all. Okay. I think actually in rickets, what happens, time management is very important because you have to cover lots of things from head to toe, but still you are able to manage. It's a good point. Yes, in the starting you asked for well communication, well looking or not, and short stature you said, and I told weight and height on less than 0.4 centile. And also, I don't know about if you asked about the surroundings or not. But you asked
Yeah,
about.
I asked about, yeah. Only I asked about anyone with similar features.
Yeah, but also you can ask about surroundings. Maybe he may not walk for a long, long
Okay,
distance.
yeah.
He may have some wheelchair or he may have some crutches or some supporting aids that you have to
Yes,
ask.
yes.
You did not ask, even though it's not there in the picture. You have to ask. So, facially, you said there is dental abnormalities, and alopecia is very clear here. And also in the family, his brother has this. Means he is completely bald, but his brother, he has started to lose the hair now. Okay. This is one of the clue for you here. And another thing, when you asked him to stand and when you do the inspection, you will look him from the front, side and back. I'm not sure
Yeah.
did you tell this or not.
Yes,
Because
no, I didn't say, I just told inspector.
yeah, but you have to tell this better.
Yes.
for your safe
Okay,
side.
okay.
You will inspect from all the sides, front, side, and back. And okay,
Okay.
your deformity was fine. It's a knock knee, but at the same time, there is some angulation even in the limbs, means you can see some angulation in the limbs as well. And no
Mm-hmm.
scars, okay.
Mm-hmm.
Other thing was, I think you completed everything. When pigals of, when we said pigals of lower limb, start, if examination is lower limb, start with pigals of lower limb. If it is just MSK,
Yeah, yeah.
you have to do complete pigals. But even if you finish pigals of lower limb, you can offer to do pigals of upper limb. Better to offer that I will do pigals of upper limb, okay.
Yes.
And when
Yes,
you
yes.
are doing pigals of upper limb, but at the same time, just look for the ricketic features like widening and also hyperextension at elbow. Okay. Like this, when you are doing simultaneously, when you are doing pigals, you can cover up the time by seeing the features. And head, okay, main feature here is the alopecia, which you said, and the teeth. Otherwise, he's fine. Okay, in the chest, yes, ricketic rosary. I think it's very clear here, you see, in this area, right?
Yes, yes, yes.
Here, and also there is slight pectus excavatum here, and abdomen looks distended. So you will always check for the liver. Okay, you will tell that you want to palpate for any tossed liver. And in the chest, it's okay. But do we have to auscultate? Maybe we may not have time, right?
Yeah.
Here,
We may
no.
not have. Mainly if there is, yeah, yes.
Here, if there are no patients.
Mainly because they are prone for recurrent infections and all. Just I told auscultate like.
Okay. Okay, maybe you can say, but here no patients, just for the sake of saying you can say, but if there are patients, I don't know about,
Yeah.
we will go for auscultation or not. I think if we missed any points, anyone can tell. And when you are complete, in order, when you are presenting your case, you missed two important points. One is the
Asking you are telling, so I finished.
extension and alopecia. So be careful. This is the points which will take you to your diagnosis. Alopecia and hyperextension. Okay. And in MSK stations, what do you see for, in order to complete, what do you say usually? Why you are telling BP in this patient? For renal?
Because, yeah, to any renal underlying.
Okay. So you told very nicely that nutrition is not more likely in this patient because he's 10 years old. I don't think we will delay the patient so late without treating. Okay, and underlying causes. I think your differentials were fine, and also the treatment. Anyone wants to add anything, please go ahead.
Is there any DD of this case?
Yeah, she told vitamin D dependent rickets, but she did not tell the type. After prompting, she told the type. And she told nutrition and then underlying causes like renal and liver problems.
Ectodermal dysplasia possible?
Yeah, we can keep like this if you like not rickets, other cause, other skeletal dysplasia, we can keep the Blounts, which they can have deformities in the lower limb. And yeah, ectodermal, yeah. I think something else
Dysplasia,
also is there,
conical
some other causes. Yeah.
Conical teeth, I mean teeth deformity, then the skin deformity, and the alopecia, all goes favor in ectodermal dysplasia also.
Yes, yes.
And but this knock knee is not so much present. Knock knee is a differential of ricket.
Okay.
And Dr. Noor, child is in the picture. See, it look like pale, significantly anemic, or it is a complexion. It could be the nutritional or underlying anemia. Could be. And see, it looks fairly pale.
You can, if it's okay, you can say anemia, but this child is actually presented as vitamin D resistant rickets. I will share you this, just 1 minute. I will share. the picture what we saw was this. Okay, in the first picture it was vitamin D dependent rickets type 2, and in that there was one picture sibling one, the elder one sibling, which is the case we discussed, showing a genu valgum and alopecia totalis. Okay, then in another picture there is VDDR2 sibling 2 showing folliculitis, precedes hair loss and alopecia. So I was telling her that this is the sibling with little hair loss. Vitamin VDDR2 sibling 1 showing premature loss of teeth. Okay, so I don't know here why the figure I could not show you, but you saw the picture when we were describing. So it was of 2 siblings. One was showing alopecia totalis with genu valgum, which is the case we discussed. The another was just preceding hair loss now. Okay, he has started the hair loss, and this child also had premature loss of teeth. So I'll read about it here. So vitamin D dependent rickets type 2 in siblings. 2 male siblings of age 9 and 2.5 years respectively, belonging to a poor Hindu family, presented with progressive deformity of the limbs, not gaining height, hair fall beyond neonatal period, preceded by folliculitis, premature falling of teeth. Okay. There is also the hair fall is preceded by folliculitis. Okay, and they had progressive deformity of limbs and not gaining weight. This was their presentation. Younger sibling had painful lower limbs and did not start walking. He's 2.5 years, still he did not start walking. On examination, all growth parameters were below 3rd centile. Okay. Both children had a classical manifestation of severe rickets along with peculiar features of VDDR2 in the form of alopecia totalis, epidermal cyst, and premature falling of teeth. Okay.
Sorry, Doctor. Sorry, just I want to know what's the difference between vitamin D resistant rickets and vitamin D dependent type 2 or type 1.
Okay, we will discuss it after this. Okay.
Okay.
Owing to the financial constraints of the patient's family, 1,25 dihydroxy vitamin D and parathormone could not be performed, but alopecia and premature falling of teeth were the strong pointers of this rare diagnosis. Then investigations they showed there VDDR type 2, also known as hereditary 125 dihydroxy vitamin D resistant rickets. This is what I was asking. The another name for this is vitamin D resistant rickets. Okay, is a rare autosomal recessive disease that arises as a result of mutations in the gene encoding vitamin D receptor. Okay, this is due to the mutations of the gene encoding vitamin D receptors. Okay, and the another name is vitamin D resistant rickets. It usually presents with early onset severe rickets, alopecia with elevated circulating levels of 125 dihydroxy vitamin D3. Learning points. All cases of rickets are not nutritional in origin, even in tropical countries. Genetic causes should be strongly considered if patient presents beyond 2 years of age with severe rickets, pathological fractures, and positive family history, and failure to respond to vitamin D. So when you will suspect the genetic causes, if the child is not less than 2 years, he is old, genetic causes should be strongly considered if patient presents beyond 2 years of age with severe rickets. And also there are pathological fractures, positive family history, and failure to respond to vitamin D. Alopecia and premature falling of teeth are important clinical pointers to vitamin D rickets type 2. So when you are seeing the patient, always concentrate whether he has alopecia or not, and also his teeth. Okay, this is for your differential. Regarding, there is one, I don't know in this I can open or not. We can read from this also so that we'll get to know the difference about the type 1. Okay. Vitamin D dependent rickets type 1. A 6-year-old girl belonging to lower socio-economic class of Muslim community, product of consanguineous marriage, presented in pediatric outpatient department with a history of progressive bowing of limbs, recurrent chest infections. Yes, they can also have recurrent chest infections, requiring hospitalization in the past and failure to thrive. Calorie and protein consumption was just 1/3 of the requirement. A family history of similar problems were present in the mother. Mother had frank rickets beginning at the age of 1 and progressively increasing with age. The mother was treated at a private clinic for the disease with 125 dihydroxycholecalciferol. The clinical examination revealed florid manifestation of rickets. Investigations showed near normal 25 hydroxy vitamin D and low concentration of 125. When they did, they could see that 25 hydroxy vitamin D was okay, but 125 dihydroxy vitamin D, supporting the diagnosis of vitamin D dependent rickets type 1. So in vitamin D resistant rickets, what happens is you will have high levels of 125 dihydroxy vitamin D. But here in vitamin D dependent rickets type 1, you will have normal levels of 25 hydroxy vitamin D, but low levels of 125 dihydroxy vitamin D, because the enzyme which converts 25 hydroxy vitamin D to 125 dihydroxy vitamin D in the renal, that is in the kidney, will be deficient. This is the reason. Okay. VDDR1 is also called as pseudo vitamin D deficiency rickets. Okay, the another name we have to remember, pseudo vitamin D deficiency rickets, is an autosomal recessive disorder occurring due to impaired activity of renal 25 hydroxy vitamin D 1 alpha hydroxylase associated with raised 25 hydroxy vitamin D concentrations and markedly low to undetectable concentrations of 125 hydroxy vitamin D. Okay, someone was asking about the difference. Did you get the difference? I don't know who was asking.
Yeah, I asked about. I think the vitamin D resistance is including both types, and vitamin D dependent type 1 and
Now,
type 2.
yeah, see, it's vitamin D dependent type 1, type 2.
I think both of them called vitamin D resistant one.
No, type 2 is only called vitamin D resistant. Type 1 is not called as vitamin D resistant. It is called as pseudo vitamin D deficiency, or you can just say type 1 vitamin D dependent. Okay.
Okay,
Because,
what about type 2? Type 2, the defect in where, and where is the defect in type 2?
I will tell you. So here, I think most of them got it. Let's see the picture of this type 1 here. Okay, see, in this case, in the type 1, the hair are very good. There is no alopecia. So whenever there is alopecia, it will give you a clue to the type 2. So here the hair is very good, but you can see other manifestations here, like pectus carinatum. Okay, and also if you can see some Harrison sulcus, you can comment. Okay, I'm not sure, maybe this one, but it's not very clear. But here there is clear distension of abdomen, and here you can see some deformities. Here also there are deformities. Okay, so this is the picture, emaciated child with so many. Here also maybe there's some callus formation or something, I'm not sure. Like this is the type 1. So he was asking, let me share the whiteboard. So vitamin D dependent rickets type 1 and type 2, both are autosomal recessive disorders. Okay. But in type 1, what happens is there is deficiency of enzyme. Okay. In the kidney, that is, I think 25 hydroxy vitamin D hydroxylase. This enzyme is deficient. So you cannot produce 125 dihydroxy vitamin D cholecalciferol. You cannot produce. So this is the defect. There is defect in the enzyme. So you will get in this, the enzyme level 125 dihydroxychlorocalciferol will be low, but the 25 hydroxycholecalciferol can be normal or can be raised. Okay, this is the finding. But in vitamin D resistant rickets, what is happening? It's opposite. You will have high levels of 125 dihydroxycholecalciferol, but it is not able to act at its receptor. This is the problem. There is resistance. Though the enzyme is more, there is some defect in the 125 dihydroxycholecalciferol. It cannot act at the receptor site. Okay, this is the problem. This is the deficiency. I hope it's clear now. You can go back and read. I think you will get to know.
Yes, thank you. I got it.
Yeah. So this was our case. Any comments? Dr. Sridevi, you want to give any comments?
No.
Okay, just for revision, can you tell about the upper limb pigals, what you will do?
Yeah, for upper limb pigals, we will just tell them to extend the hand, look for any asymmetry.
Okay.
And similar features we will see in the both hands, like any reduction in the bulk, both the palmar surface and both dorsal surface also. We have to check in the hand and also upper, like arm and forearm.
Okay.
Any skin, any scar mark. These things we will see. Then I will tell them to make a fist.
Okay.
Make a fist to look for anything like for shortening of 4th, 5th metacarpal, something like that. And obviously during this time we will see the all joint swelling also, if anything, any difficulty in flexion extension of the these fingers. Yeah. Then tell her to pronate. Okay. Hand to turn out, and then we will check the any tenderness in the metacarpophalangeal joint.
Okay.
After that, I'll tell her to join both palms and then back to back.
Okay, like prayer sign you are telling.
Prayer sign, yeah.
Okay,
Prayer and reverse prayer. Then I'll tell her to raise both the hands up and look up.
Okay. Both
after that to
both for neck and shoulder at once you are doing.
No, we will do first raise the hand, then to look up separately.
Okay.
Then I'll tell keep the both hands behind the neck. Okay, and then after that we'll check for all the neck movement by touching the ears to the shoulder both sides and turning side by side, and then putting the 3 finger inside the mouth.
Okay. I think you left one thing. You should, as you said, bring the hands behind your neck. At the same time, they should also bring the hands behind the back, right? You got
means straight and back.
Yeah. Means at the level of lumbar region, they will bring both the hands behind at the level of lumbar region.
Yeah.
That one. You have this up and behind, I think is for internal rotation, right? Up and behind is for external rotation. When you bring behind, it will be internal rotation. If we show pictures, you will know. Okay, next.
Okay. Yeah.
That's all, sir.
Okay. That's all.
Okay. Okay, so I think we finished this case. If anyone has comments, go ahead. Okay, if no comments, actually I will, after 10 minutes, we'll just go through some MSK points from Mark, okay? but I just need 10 minutes, so I will end it now and we will restart. Okay,
Okay.
or maybe
Thank you.
for 1 hour or something, we will do some MSK from Mark. Okay, thank you.